Okay, great. Well, welcome everybody online who's joining us, and welcome especially to Hardy folk who've made it in person. This is our first in-person annual lecture, I think, since the COVID pandemic. We are the survivors. I can feel the spirit of Tina Turner in the room somewhere. We're the people who've managed to keep going and come through a heck of a time, really, for everybody in their practice, in their work in the NHS. My sense is a lot of people are really suffering burnout, huge rates of attrition in NHS mental health services. So I think there's a long road to recovery, and the issues that Patrick are going to be talking about could not be more timely and relevant for us to be thinking about how we apply psychoanalytic ideas to be supporting our colleagues and patients. So Patrick, as you can see, is Professor at the University of Leuven in Belgium and also at University College London. And I know Patrick really through you being, well, you've been a long collaborator and colleague with the stars of our sort of research field, Sid Blatt. You're a long time colleague of Sid's. And then more latterly, I know you through the sort of dream team of Peter Fonagy and Alessandro and Maritaggio as one of the team involved in developing dynamic interpersonal therapy. So I know that we're in for a treat tonight, lots of stimulating ideas and thoughts. So over to you, Patrick.
Okay, thank you so much, Jeremy, for this introduction. There seems to be no pressure at all on the tonight, and also very warm welcome to the people at home. This seems to be indeed the new normal in the post-pandemic times. That there's a few people in the room, and the rest of them are comfy at home on their couch with a glass of wine or tea or whatever. So good, excellent. I'm tremendously delighted, honored to be here today, to be invited. And so this is what I plan to do today, is to talk a little bit about functional somatic disorders or somatoform disorders, and then devote most of the evening towards discussing a contemporary psychodynamic approach to functional somatic disorders. So where we are now in terms of our understanding, but also treating individuals with long-term health conditions or somatic conditions or somatoform conditions. And I will focus on some of the key adaptations to dynamic interpersonal therapy that we developed over the past decade or so. And I want to keep as much time as possible for discussion and exchange with people here in this room, but also on Zoom or YouTube or wherever you may be. And perhaps to start off, apologies for my English, particularly when I'm tired, at this time. Sometimes I struggle to find my words, so apologies. So do not hesitate to interrupt me and just ask questions for clarification. This is the new manual of dynamic interpersonal therapy coming out next year. And as you can see, there's a chapter also on functional somatic disorders. It's the final chapter. When everyone is really tired, they can read the book and understand that it is a condition. Okay, this is coming out fairly soon. Get a full trial soon. So, what I'll focus on somatic disorders. Also, familial co-aggregation. So these things tend to run in family. So you often find relatives with similar complaints or other types of functional somatic disorders, also other types of psychopathology. And very importantly, every medical specialty has its own functional somatic condition. If you look at these specializations, internal medicine, for instance, chronic fatigue syndrome, cardiology, non-cardiac chest pain, functional palpitations, neurology, tension headache, migraine, conversion disorder, and so on and so forth. And what is very important to realize is that often depends more on where the patient enters the medical system, which diagnosis he or she receives. rather than reflecting a true kind of diagnosis of problem. They're highly prevalent across a wide variety of disorders as well. This is very important if you or anxiety or eating disorder, or PTSD, or complex trauma, or personality disorder. Most, if not all, of these patients tend to face for these problems. Patients who are diagnosed with other kind of disorders, which again is an artifact of our medical system, reflecting true etiology or pathogenesis. Also, these are not, I might become slightly provocative here, I realize, but I'm close to the exit. These are not medically unexplained disorders or symptoms. Neither are they psychosomatic. We really should stop using these terms. It's not only completely wrong from a scientific point of view. We know a lot about the biological abnormalities involved in these disorders, as well as psychological factors that are involved, such as the HPA axis, or the hypothalamic pituitary adrenal axis stress system, the immunological system, neurotransmitter systems, and from a psychological perspective, we know a lot about the influence of attachment dimensions and history, impairments in mentalizing or affective function or embodied mentalizing. If you are not familiar with these terms, do not panic. I'll try to explain them in a minute. And particularly also we came to realize in the last 5 to 10 years issues concerning epistemic trust, so the capacity to trust other people as sources of information about the self, others, and the world. So these are not medically unexplained or psychosomatic conditions. It's very important to realize. I do a lot of training and teaching in Germany, and there you have a huge tradition, thankfully, on psychotherapy and psychosomatic, so psychotherapy and psychosomatics, which is marvelous, this tradition, but also often not helpful to therapists, because they, on their door, they have a note saying psychotherapist X or Y, and it says psychotherapy and psychosomatic, and psychotherapy and psychosomatic. That kind of gives it away for the patient that knocks on that door. Yeah. It's not helpful.
Sorry, Patrick, does anyone actually know how common autoimmune disorders are in people with chronic psychological distress?
You know.
And can you repeat the question?
Yeah. Is it
Yeah, I mean, yeah.
immunological conditions?
Of common regarded medically explicable disorders in people who've either got, you know, what's that thing the GPs talk about? Cumulative adverse events in childhood, or just chronic psychological distress.
I wouldn't know the exact numbers, prevalence, but probably very high prevalence, but probably very high. Yeah.
I just wondered if anyone knew the number. Yeah, okay, thanks.
So these numbers are probably very high. Yeah. I would estimate about half, or even more, of patients. So good. And the same goes for long COVID. I mean, if you look at long COVID, at least 10% of COVID-19 patients still report symptoms at 6 months follow-up, consisting of fatigue, shortness of breath, headache, problems concentrating. And what is very important is that these symptoms often disappear and reappear after a while. And there's a very nice qualitative study on long COVID patients showing the following, that that long COVID as chronic fatigue syndrome, for instance, presents as a kind of confusing illness, at least for the medical profession, with many varied and often relapsing related symptoms and uncertain prognosis, such as a heavy sense of loss and stigma, difficulty accessing and navigating services, and difficulty being taken seriously in achieving a diagnosis and related to disjointed and siloed care often. And there's been consistent variation in standards and variable quality of the therapeutic relationship, with some therapists being very understanding and other therapists really fobbing off patients. So again, we're presented here with a condition that all people are desperate to either understand or interpret as a kind of medical condition instead of a biopsychosocial condition. And this leads us to controversies about treatment. We know that treatment effects of evidence-based treatments are relatively limited in a substantial proportion of patients with functional somatic disorders. And on top of that, many of these patients are known as difficult patients, leading to major transference, countertransference issues and problems consisting of irritation, feelings of powerlessness, hopelessness, helplessness, anger and aggression, and particularly also misunderstanding. Are you familiar with these feelings and experiences and so on? And so one of the key points of my talk tonight is that these patients are not difficult to treat or not hard to reach. The hard to reach character of these patients is in the eye of the beholder. Yeah? It's down to us, not them. What I will argue is that these individuals have developed a kind of adaptation strategy, or ever maladaptive with an adaptation strategy to certain circumstances, developmental history, but also often the consequence of their symptoms. If psychotherapists have the flu, they are certain they are going to die. And before you say it's the man flu, I've observed that in women as well. I'm going to die. If that's considered to be very normal behavior, or if you have a toothache, you say, oh, I'm awful, I can't think, I can't sleep, I need to get rid of this toothache. If we say that, that's considered to be perfectly normal illness behavior. But if we see patients who've been in pain or fatigue for 5, 10, often 20 years, suddenly they are highly pathological creatures. You know? They have hysterical, narcissistic, borderline personality features. That is simply not the case. It's not true. So, in trying to make my case, I will focus on 3 issues. So first, attachment issues in individuals with functional somatic disorders. Second, problems with mentalizing, and particularly embodied mentalizing, so the capacity to reflect on body and the relationship between bodily features and experiences and emotions and interpersonal relationships. And third, epistemic mistrust and even epistemic vigilance and hypervigilance in some of these individuals. And so I will try to walk you through each of these issues. And here's my proposal. If you do not agree with me, or you do not recognize anything, stop me and say, Patrick, I do not recognize it. Patrick, I do not agree. That will be extremely helpful to me. So if you look at attachment issues and functional somatic disorders, this is highly relevant. So how the attachment works emotionally, this is a kind of evolutionary PY, biological system, that human beings are born with an attachment system, and it's as essential, as key as our stress system. It even regulates the stress system, as we will see. So how this works is that any distress or fear activates the attachment system. And here's a room full of very experienced therapists. How do we know that the attachment system is activated?
The first thing that a child does when they encounter something stressful is run to their parents.
Yeah. Proximity seeking to attachment figures. You know? So we see our attachment figures for support, care, love, understanding. And when you're familiar with this experience, you know that this leads to kind of down-regulation of emotions, that we feel understood, validated, supported, loved, cared for. So if anyone recognizes this feeling, that's an indication of secure attachment. There's a slightly insecurely attached person has a question.
Of course, we're screwed because we've got like 1 or 2 attachment figures.
Yeah.
And I know you know the story. If you live in a village and you've got 6, 7, 8, 9, 10, remain protected from some of these horrendous.
So exactly, people often have very few attachment figures, but even more so, emotion and stress and arousal regulation is thus co-regulation. We always need other people to co-regulate. But what happens if you do not have these people, or you have the underlying belief that these other people won't be available, won't be there for you? But also, what if the threat comes from within and you can't regulate it or co-regulate it, like pain? Yeah? Remember the flu? Yeah? I mean, if someone brings you a hot cocoa, that might relieve the pain a little bit, but the pain doesn't disappear. You're still ill. So this is the condition that many of these individuals are in for a number of years. So they do seek proximity, but there's no possibility of effective co-regulation because the pain or the fatigue continues to be there. And this is how these individuals come to see us in a fight-flight state, not in a calm state, but in a fight-flight state. Help me, because I can't regulate it, and nobody else can co-regulate my pain or fatigue or my symptoms or my problems. So what if the threat comes from within, and there's an inability to co-regulate or to regulate? And this is then where attachment styles and differences in attachment styles kick in. And as you can see, I'm a marvelous artist. This is my drawing talent for you. But I think it does a very good job in depicting, very schematically, but in depicting differences in attachment style and the influence on mentalizing and embodied mentalizing in particular. So you have individuals who tend to use deactivating attachment styles, where there's a huge emphasis on cognition to the neglect of affect. So they deny any distress, they deny the importance of emotions, of relationships, of emotional experiences and relationships in general. They have a very massive head and are not in contact with their body and their bodily experiences. Whilst people who use hyperactivating attachment strategies in response to distress, there's a huge focus on affect to the neglect of cognition. So they're constantly overwhelmed by these emotionally embodied experiences of pain, fatigue, catastrophizing with our colleagues from the CBT tradition. So this is how it looks. So people with attachment hyperactivating patterns, they respond to distress, to the failure of co-regulation by clinging on to other people in a desperate attempt to help, including you as a therapist. Help me, give me tips, give me extra sessions. So there's a typical pattern of fast attachment to others that are often idealized. But you know, idealization always entails a possibility then or a switch to denigration, which may quickly follow. You do not understand me. You're another therapist who thinks it's all in my mind, all in my head, so you can't help me. And so there's often hypersensitivity to rejection. Whilst the attachment deactivating pattern, these individuals typically assert autonomy and independence as a defense against underlying attachment needs. So these are kind of dominant goal-oriented people, often characterized by overactivity, constantly work, even on a Wednesday evening. They give lectures or attend lectures and so on. None of this is related to us. And hypermentalizers, is sometimes a derivation of mentalize as such, hence why they're often called in the psychoanalytic tradition alexithymia, from the Greek no words for emotion, alex, tume. So they have no words for emotion, which only I would partially agree with. This is how it looks. I'm learning how to relax, doctor, but I want to relax better and faster. I want to be on the cutting edge of relaxation. You know, these individuals, I've been severely traumatized, abused by my father, but it didn't hurt me at all. By contrast, this made me stronger. I'm a lot stronger than most people. I can handle adversity. I can handle negative experiences. Never had a problem with anything. And then, unfortunately, we see a lot of patients who have a disorganization of the attachment system, either pre-morbidly and before the onset of their complaints, but often also as a consequence of chronic pain and fatigue, because that typically leads in the long run, or tends to lead to a disorganization of the attachment system, where you see an oscillation between hyperactivating and deactivating strategies. So they cling on to you and then they reject you very quickly. And there's a very popular book about this dynamic, I hate you, don't leave me. So you typically see two contrasting interpersonal dynamics with often rapid oscillation between both. So in deep terms, you see two epochs, two interpersonal affective shortcuts, leading to hypermentalizing cycles. And this is the reason why I do not fully agree with the alexithymia literature, because that suggests that there's an absence of the capacity to reflect or to talk or to feel and so on. And this is not really true. So this could lead to a tendency for hypermentalizing or mentalizing on the loose, pseudo-mentalizing. So these individuals can often go on and on and on and on and on about mental states, and then quickly switch to hypermentalizing, where they do not feel like reflecting about emotions or experiences and relationships at all. You had a question?
Yeah, I didn't really want to ask. Are you familiar also with the opposite of society of the term interoception issues?
Yeah.
And I find that a much more comfortable term.
Yeah.
Because some people are born with some of those issues, some people don't develop.
Yeah.
And I find it much more, like you said about some of the others,
Yeah.
much more helpful than an alexithymia. I wish alexithymia was for any of the beings there.
Yeah. I think that's true.
Do you mind saying that term again?
Interoception, it's your body, state of your body awareness. It's a growing literature from OTs and other professionals about looking at alexithymia is a bit of a barrier to it over the years because it's been almost described as a condition rather than the fact that we evolved these developmentally in systems. And sometimes these systems can be dysregulated, but sometimes people are born with what you might call alexithymia condition without anything. So interoception
Interoception is
woman
an
can tell you about
interoceptive awareness.
That's about positive awareness.
Yeah, interoceptive awareness is, are you aware, for instance, that your heart is beating now, that your blood pressure, that you're sitting on a chair now and there's pressure is on your legs, are you aware? More that you're cold or warm.
But sometimes it can shut the system down. You can be more anxious and actually your sense of taste, smell, and other factors actually diminish. So it's two ends of the spectrum.
Exactly. And this is a very nice picture to problems with embodied mentalizing. I'm very grateful for that link. That's the second area. For those of you who are not born with the definition of mentalizing, it's a capacity to reflect on ourselves in terms of internal mental states that we're motivated by beliefs, goals, emotions, wishes, attitudes, and so on. And what we see in patients with these features is particularly problems with embodied mentalizing. And if you look at embodied mentalizing, it entails at least 4 dimensions. First is recognizing emotions. This relates to interoceptive awareness. Most of these patients only can tell you that I feel bad or tense or awful. And you've been trained, you have all years of psychoanalytic training and supervision by Jeremy, so you know what to do then. And so you ask them, what do you mean by you feel bad? And they respond, not good. Again, years of experience and training kick in. So you do not give up and you say, what do you mean by not good? And you respond by, bad. So that this is the reason why often people say these individuals are alexithymia, which is not completely correct. It's part of the story, recognizing emotions as emotions, but also ownership of emotions. Many of these individuals are actually infected by other people's emotions. So this contrasts with the notion of alexithymia, but it can also be a disowning of emotions, particularly in attachment deactivating individuals. Yeah? Like the example I was beaten by my dad all the time, but it didn't hurt me at all. That contrast made me strong. So there's a disowning of vulnerability, of anxiety, sadness, and anger, and so on. Third dimension is the ability to reflect on and modulate emotions And the fourth one is the ability to share emotions in appropriate ways. Many of the individuals with functional somatic disorders have the conviction that showing emotions is a sign of weakness, for instance. But it can also be the opposite, that you quickly share everything, the whole life story. I'm sure you're familiar with that as a therapist. You can also encounter these individuals on a long flight, for instance. So these are four very important dimensions, and what is crucially important from a mentalizing perspective to functional somatic disorders is that impairments and distortions in mentalizing, and particularly embodic mentalizing, can be the cause of functional somatic disorders, but also in part the result. Again, if you live with chronic pain for years, your mentalizing capacities are reduced to virtually nothing after a while. I can assure you. It's very difficult to continue to mentalize, and particularly to mentalize about your own body. So experiences or utterances like, I consider my body as a machine that is dysfunctioning at the moment, is very understandable. Kind of the disavowal of the body and as something distinct from the psyche is very understandable. And this further exacerbates symptoms and complaints, leading to a hyperactivation of the attachment system, non-mentalizing, and a pressure to externalize these non-mentalized alien self features, which you as a clinician begin to feel. I have a practice that is about 8 minutes removed from my office at the university department, and so when I after seeing a few of these patients, I go to my office. I usually go like this. I begin to feel what they feel. This is called externalization or projection of these non-mentalized experiences, leading to a negative interpersonal cycle that increase symptoms. And so a number of these non-mentalizing features is psychological equivalence. I'm certain about what you and others feel or think. So I think there's a virus causing my problem, so a virus is causing my problem. So we have to find and get through of them. What I think is real, to the extent that everything becomes too real, even thoughts and feelings, and rejection literally hurts. So there's a kind of a failure to distinguish between psychological and somatic pain. Leading to very painful feelings of shame, sadness, emptiness, badness, which also threaten to disintegrate the self from within, and often the only means to deal with those feelings, unmentalized feelings, is, as I noted, evacuation by means of projection, dissociation, and self-harm. And here there's again a fundamental risk of misunderstanding, that you as a clinician do your best to understand the patient, but the patient experiences you as another unresponsive, rejecting other that not only doesn't understand the patient, but willfully misunderstands the patient, as an unresponsive, intrusive other. And in supervision, we use videos, for instance, we often see this happening, where the therapist kind of very well intended says something like, I think, you know from research that stress may affect a condition like yours. And you see the patient kind of exploding internally. And often they're very nice and they say things like, I'm not sure. Whilst they think like, I want to kill you. Because you do not only not understand me, but you willfully abuse me. So we should be very careful for this. Teleological mode, second mode, where there's only goal-directed observable states, a primacy of the physical observer. I only believe it when I see it. Again, the virus causing my symptoms. And saying things like psychological, when people are in a teleological mode, so even suggesting that psychological factors may contribute to their symptoms comes across as immensely cruel. It amounts to the same as, I'm not going to look at anyone specific now, but if you're working with a patient who's bald it's the same as suggesting to that patient, stress might have affected you becoming bald. It's the same. People in a teleological mode have a conviction that indeed only the observer, only the physical can affect their condition. Third mode finally is extreme pretend mode and intellectualization. Again, unmentalized experiences give typically rise to either cognitive hypermentalizing, intellectualization, rationalization. My patients bring the latest papers on chronic fatigue syndrome or fibromyalgia on that condition to me. I say, thank you very much, I haven't seen this. Or they spend hours reading on the internet, particularly in the UK. Patient organizations are very into kind of putting together the latest biological, biomedical research on these conditions, or affective hypermentalizing, where people are completely overwhelmed by their own confusing narratives, like I never stop thinking about origins of my chronic pain, and this increasingly confuses me to the point of dissociation. Particularly in traumatized patients, you then see kind of dissociative states of mind. And this is typically kind of the elephant in the room where the patient is blah, 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 but cognitive hypermentalizing or affective mentalizing. The therapist is becoming increasingly frustrated, whilst the elephant in the room is this is kind of hypermentalizing. What was the question?
I'm just wondering what the link between issues not being able to mentalize and
Teleological mode.
mode is, yes.
Yeah. So, I mean, these pre-mentalizing modes emerge when you lose the capacity to mentalize. So you revert to earlier modes of understanding your own subjectivity, like psychic equivalence. What I think is real. In infants, for instance, what I think is real. There's an equation between psychological reality and external reality. Teleological mode is very similar. So when you simplify the world and your experience of yourself and other people, you often revert to a teleological mode of reasoning. If you really love me, you stay with me. You do not go out with friends. Just a random example. Or the patient saying, if you really care for me, you give me an extra session. So when we lose our capacity for mentalizing, we revert to earlier modes of thinking, reflecting about ourselves and others. The psychic equivalence is one, the teleological mode is another one. And the pretend mode is still another one. There's 3 modes. And I'm glad you asked this question because these non-mentalized experiences not only give rise to kind of teleological, pretend, psychic equivalence thinking, but these modes of reflecting on the self and others do not solve the problem at all. By contrast, they lead to an experience that something's not correct, something's not wrong, to alien self parts being, to a pressure to externalize these alien self parts. It's not me who's at fault, it's someone else. So there's a need for containers. By externalizing these unmentalized aspects of the self, a sense of coherence is achieved. But this leads to a constant need for a container. You do not understand me. You're the awful person, not me. You're wrong, not me. I'm correct. And that restores a sense of coherence for a while, but not for long. That's one disadvantage. And the second disadvantage is that you need someone else to blame. And most of the time, this is you, therapist.
Well, this is us.
Yeah.
Us therapists, not the person themselves who thinks they're weak.
Yeah.
Do you think?
Yeah. So this is a kind of model where biological factors, environmental factors lead to increasing stress, or what is also called allostatic load. Human beings, our bodily system doesn't function according to a homeostatic system, but allostatic system. So we constantly have to adapt to a different environment, like here. It's rather cold here, Jeremy. So we all need to heat up our bodies. So our body is now in allostatic, trying to reach a new level of allostasis. But after a while, this fails. So when stress increases, you have allostatic load. So there's no possibility more of achieving allostasis. And we respond to that by relying on secondary attachment strategies, attachment hyperactivated, deactivated, mentalizing capacities become impaired because chronic pain, fatigue, and these symptoms, there's no possibility of co-regulation, so increasingly our mental capacity is negatively influenced and leads to all kinds of perpetuating behavior that only serve to increase stress and allostatic load. And there we go, in this vicious cycle. And this is how these patients typically come to see us, often after having met with many other health and mental health professionals who are unable to co-regulate their distress as well. And this leads me to the final bit, problems with epistemic trust. This is something that we've come to realize. Trust, and particularly epistemic trust, opens up social communication super high, enabling us to learn and to change. But many of these individuals, either because of a history of early adversity and trauma, but often also as a consequence of many encounters with health professionals and mental health professionals that weren't able to understand them. This led to kind of epistemic mistrust and often epistemic hypervigilance. And so in many of these individuals, epistemic mistrust was once adaptive, particularly in the ones with a history of trauma. But even in the patients who develop epistemic mistrust as a consequence of their condition, this is kind of adaptive. This protects you against disappointment. Do not trust other people. This will be another therapist saying that's all in my head, all in my mind. So again, the hard to reach character of these patients is in the eye of the beholder. From their perspective, it's a very, very understandable adaptation strategy. If you're growing up with unreliable attachment skills, with unreliable others, it's adaptive not to trust others. If on top of that, you have many encounters with health professionals who do not get you, it becomes quite adaptive to expect that they, again, will not be reliable. And this has led to a number of key adaptations for patients with functional somatic disorders in dynamic interpersonal therapy. I'm not sure whether everyone's familiar with DIT, so I'll briefly explain some of the basic assumptions, but in doing so, it's time for humility. How could I possibly, in a room full of seasoned, experienced clinicians, tell something about DIT and perhaps new developments in DIT? So this is a sign that is standing somewhere in the UK, and it's a sign not in use, so it's completely superficial. Who needs it? So who needs me? But perhaps you need me to tell you that there's quite good meta-analytic evidence for psychodynamic therapy in functional somatic symptoms. We've done 2 meta-analyses, one of RCTs, randomized clinical trials, showing that PDT is more effective than minimal treatment as usual, waiting list controls with small to large magnitude effect sizes, and was at least as effective as other bona fide psychoanalytic therapies like CBT. We also did a meta-analysis of naturalistic studies, so not randomized controlled trials, with similar conclusions, and particularly treatments longer than 12 sessions. In this country, almost denoted as long-term psychotherapy. It shows larger effects. What is typical of DIT, and this is the example of a 16-session model. We also have a 26-session or 40-session model developed, clearly structured in 3 phases. Initial phase, which consists of engagement and validation, particularly in these patients. We need to engage them and particularly validate and normalize their pain and suffering and the whole subjective experience that they've gone. In addition to assessment and case formulation, DIT is an interpersonal formulation. So now, typically, the repetitive pattern of relating to others or an attachment pattern is linked to presenting symptoms. Middle phase working through and at the end. So again, the starting point is an interpersonal formulation. So this regulation of stress, of distress, is co-regulation. And what we typically see in these patients is a failure of co-regulation. So the threat comes from within, and there's no way that you can effectively co-regulate when the threat comes from within. So there's this down-regulation of emotions doesn't happen or insufficiently happens, so we need to help them with that. And hence, the double focus in the IP. There's a focus not only on the content of the dynamics, this repetitive interpersonal pattern that is associated with the onset or persistence of symptoms, but first and foremost, we need to recover and sometimes even develop the capacity for effective function, to reflect on what is happening to them. That's the mental process for it. But this is a typical IPAF, for the self-representation, like I'm misunderstood, I love weak object representations, others always reject me or criticize me, the affect linking the two, like helplessness, anxiety, depression, loneliness, but importantly also the defensive function of this conflict. For instance, the avoidance of own aggression. I've grown up in an environment where I had to develop a sense of weakness, of feeling misunderstood and unloved. But this is an adaptation strategy. And what has been defended, what I couldn't feel or experience all my life was experiences of frustration and aggression because of it. Where am I in this whole story? So these are typical themes related to IPAFs in patients with functional somatic disorders. Someone always wants to do everything for others, but has the feeling that there's no return and becomes increasingly depressed and fatigued. So this is often a compulsive caregivers. Take care of other people, but who takes care of me? Or someone feels always inferior to others, also and often particularly in close relationships, and constantly fears to be rejected and abandoned, and symptoms of pain incapacitate the patient more and more. This is more dependent pattern. Or someone believes that he or she has to be able to face and achieve everything, but feels more depressed and tired each day. This is perfectionism or attachment, deactivating stress or presentation. You recognize these patients?
Actually, what did IPAF stand for?
IPAF is the interpersonal affective focus. So this is the central focus in the IP. This repetitive pattern, which I showed you, this is the IPAF. So this is self-representation, object representation, affect, and the defensive function. So this is the typical pattern or attachment strategy in MBT terms that someone has developed over life. As an adaptation strategy to a particular biological givens and environment and interaction. If you're not familiar with these concepts, think about a schema or object relations diets or attachment working models. A bunch of terms involving very similar things. So again, particularly in the early phase, this means that in these patients there needs to be initial focus on mentalizing rather than the underlying dynamics. And this is what we learned over time. If you move too quickly into more interpretive interventions, this is likely to surpass the capacity for mentalizing, because people are in fight-flight state, increasingly leading to epistemic mistrust and even epistemic hypervigilance. You do not believe there's something physically wrong with me. You're just like all the rest. So what we start with is empathic validation. I hear myself saying things like, you do not have to convince me of the reality of your symptoms. I can clearly see that you're suffering. Defensive externalization. I feel bad, and now you're telling me that it's all my fault? How is this possible? So you're suggesting that stress is involved, so that I have a role to play in all this? I can't believe it. I can't believe it. And the feeling that one is understood. I really can't follow it. What do you mean by that? You do not really understand me. Similarly, an overly neutral stance is similarly felt as non-caring, aloof distance, and leading to high dropout and regression. So you need to be there in the room with the patients. And these are the three key conditions or key adaptations of the DIP model that we developed over the past 10 years or so. So first is great importance of empathic validation and particularly supportive and normalizing interventions more generally to counter epistemic mistrust and hypervigilance, and to normalize and validate the impact of somatic symptoms and its impact on the mental and capacities of the person. Second key adaptation is we need to be able to move very flexibly along the spectrum of interventions tailored to the patient's specific attachment style, whether that's more hyperactivating or deactivating or a mix of the two, disorganized attachment. So we need a very specific and detailed assessment of both attachment styles and mentalizing capacities early on in the treatment, and we need to be able to flexibly adapt to these attachments. And fourth, a great focus on improving embodied mentalizing through what we have called, using an MBT term, micro-slicing of interpersonal experiences and events based on a not knowing inquisitive style. So what we typically do is we ask the patient to recollect, to focus on specific interpersonal experiences and slowly, gradually start to mentalize, to reflect together what was happening then. And we start off by validating, normalizing interventions. To do that, we refer patients for thorough medical examination and follow-up, and we acknowledge the reality of symptoms and the possibility of biological causation. I wouldn't want to be the therapist who treats a patient with a brain tumor, to be honest. So all my patients, which were thorough medical, I had a close collaboration with internal medicine at my university, and so I send them all to the clinic first. That also helps to restore agency and mentalizing, and thus restores great epistemic trust, which is key in the initial phase of treatment. We need to establish a we mode where we can try and begin to understand what is happening to you together. And this is again borrowed from the MBT tradition in the meantime. Most of our patients come to see us in the I mode, in the non-reflective experiential mode. I have these terrible symptoms and I want to get rid of them. And there's very little or no capacity for me mode to reflect on what is happening to you, and particularly embodied reflective function, embodied mental. And this is a start. You need to move patients from I mode to a me mode, but then to a me mode where we together can begin to reflect about your mind and my mind together. The middle phase, how to foster embodied mentalizing, is the central task. So we have a whole spectrum of interventions, again supported empathic, more insight-oriented interventions where clarify, elaborate experience, challenge them, leading to more basic mentalizing, including often the necessity to mentalize, to reflect on the therapeutic relationship. This is often typically inevitable in basic functional somatic disorders. But this is not easy. So we ask very difficult questions. So the patient has things like, the way I feel is hard to quantify, and then we insist how hard on a scale of 1 to 10. And so we develop a kind of strategy using this not knowing inquisitive stance to start micro-slicing experiences, using this rattle sequence of intervention. Briefly talk you through, because I'm fully aware that we need to end. So in DIT for functional somatic disorders, we closely attend to somatic markers of the mental states, to facial markers like frowning, blinking fast, scowling, smiling, voice, stuttering, sudden change in pitch of voice, specific bodily markers where people start hand clenching. You know? I was beaten by my father, but it didn't hurt me at all. I've become stronger because of it. You know? Sighing, sweating, vomiting, and so on, body posture, moving back and forward, making myself seem bigger or smaller. So it's a very embodied way of working, and particularly in the early phases, this seems to be relatively new for many psychodynamically trained people, so hence the importance of video-based supervision. Where we start with is recognizing emotions, and it's a timer interoception, a physical sensation, a proto-emotion after you're tense or nervous, to felt emotions that can be labeled, that's the cognitive part, and felt at the same time, that's the affective part. So we try to integrate cognition and affect, and we try to label emotions through mirroring. So we tend to, when someone says awful, we tend to use our own mind, say things like, what do you mean by awful? Is that you feel frustration or anger or sadness? So we try to mirror what the patient is feeling. And we mirror it also by amplifying, because these patients feel and do not feel at the same time. So we need to turn the volume loud, so we need to amplify that. Of course, not too loud, because then boom, the arousal becomes too high. And then begin to differentiate between emotions. Any mental state typically involves several mental states. This is Putin, feeling normal, disappointed, happy, thinking, and this is Obama. So we need to start not only recognizing, but amplifying these different states of mind. For instance, that someone feels sad because he feels rejected, and then feels lonely, and then becomes to feel frustrated and angry, and then shuts down because of shame. And this is a kind of very detailed process that we achieve through microslicing. But the advantage of microslicing is that then it's on the table. You saw it once, this sequence, what is typical, this typical interpersonal pattern of the patient, including this focus on attachment deactivating hyperactivation strategies. So in these patients, we will have to massively often increase the arousal to get them to feel. In hyperactivated patients, we typically have to support, scaffold their cognitive capacities to label and to feel at the same time. And so, like I was saying, this exercise leads you to then link emotions together, but also to the patient's core dynamics, to this interpersonal pattern of if someone, for instance, quickly feels rejected, then feels sad, then becomes angry, and then shuts down because of shame. This is an individual who just learned, quote unquote, to shut down whenever she felt angry. And then what was left was this unmentalized feeling of anger and shame and sadness and rejection, which was felt as pain and fatigue and emptiness. So I come to a number of conclusions. But we still have time for discussion, hopefully, is that first of all, chronic somatic symptoms and complaints are highly prevalent in all of our patients. Once you see them everywhere. And this fosters emotional processing through microslicing, which appears to be the main mutant effect in addressing these complaints across different treatments, which is what evidence shows. And this again points to the importance of embodic mentalizing. So again, harking back to the theme of tonight, the fact that the hard-to-reach character of many of these patients is in the eye of the beholder. I would really urge you to take the notion of embodic mentalizing serious and try to put yourself in the shoes of someone else, like someone with functioning somatic disorders, because only then you will start to see and feel particularly how it is to be. Thank you to all team involved in these developments, and for more information, if you're interested in training even after this talk, feel free. Thank you.
That was a brilliant, really clear explanation of what a skillful process it is with these kinds of patients.
Should we use a microphone so that
Yes,
people
please.
at home?
People at home are having difficulty hearing the questions.
Yeah.
Okay, so I'll bring the microphone around then.
This was a bit of mentalizing action.
that was a brilliant and clear explanation of just what a skillful process it is in reaching these patients, rather than, as you say, the kind of traditional way in which we tend to respond, which is to sort of emphasize the pathology or fall back on kind of pathologizing ideas and theories about these patients. Although one of us are going to end up with Vladimir Putin as the patient that we're trying to reach.
This was all about other therapists. No therapists in this room or on Zoom or YouTube. Other CBT therapists.
So, any questions from people here? Is there anything coming in
Yes.
online? Do you want to?
Andy, can we
Microphone
get some of these
over.
questions?
Do you want to read out some of the questions online?
Take some from the room first, and we'll sort out the online
Okay.
questions.
Yeah.
And please feel free to be critical.
Martin.
It is interesting bit.
Thank you. First, a very teleological thing.
Can you scroll?
Patrick, could you send sort of PDF of the slides, please?
I could, but I won't. No, definitely. Yeah. All the slides you can.
The first microsecond of that, I thought you were serious. It's obviously my insecure attachment style.
I will happily share all the slides and PDFs and papers on the topic. Should anyone be interested?
And it's recorded as well, so you can watch it back.
Can we watch it back?
Yeah.
Oh, fabulous.
Oh, dear. Okay.
Sorry, I've had some red wine, so I'm easily laughing. Can I go back to the we mode?
Mhm.
The first thing is a self-observation. I'm working with someone at the moment, and I initially complained about having to use the room that's got couching for trainees. And I now have found that I sit on the couch next to the patient. I think, and I value your observation on this, I think I am trying to emphasize the we mode in which we both look at her situation across the other side of the room, rather than being in a across the room situation where she says I'm evil and I say no, you're not. And then my follow-up, sorry, I'm trying to get it, is how much I found myself disclosing a lot about me. And I feel on thin ice. And I wondered if you had any wisdom about that.
When is my boss? No, but clearly, I mean, this is slightly teleological as well, sitting together next to the patient and so on, but it may help. So it's actually joining side by side, not kind of in a hierarchical way, or even setup, looking in the we mode at the patient's mind. And I think, for instance, in the humanistic tradition, there's the empty chair technique, for instance, where they use that technique. Empty chair, are you not familiar with that? Okay, so, yeah, in the Gestalt, it comes from the Gestalt tradition. For instance, where the patient is invited to be the father, for instance, or to be mother talking to the patient. So that's a typical technique. It's simply fostering metacognition, you could say, and mentalizing. So there's various ways indeed to induce this we mode. And what in DIT, for instance, helps is to draw the epath on a blackboard or on a flip over chart. And I know that many psychodynamically trained therapists have kind of phobic anxiety to do that. But once you get over it, you'll find that in some patients at least, massively helpful, that they are then the two of you are looking at the patient's mind together, from a third perspective. Instead of being in this dyadic interaction and relationship, which is bound to lead to massive projections on you. And that's very difficult. It's like sitting in a group therapy where all group members are angry at you as a therapist. How can you escape this? So you need to involve a third. And there's various ways to involve a third position. And one of them is sitting next to each other, for instance, and saying, let's look at what is happening here together. Because I'm very and this is not an inquisitive stance, I'm very interested to learn, and this is also where the MVP stance comes in, is to say things like, because you are to blame for this rupture in the relationship, whether you like it or not. So you have to own up to the fact that you did something wrong. So saying things like, look, obviously I tried to do something good or well, but I failed. I must have said something that hurted you. I'm sorry for that, but I would really like to understand what it is. Can we look at it together? This is really.
The ice has got a little bit thicker, thank you,
Yeah.
Patrick.
And the disclosure, I would be slightly careful. I mean, in DIT, there's limited self-disclosure. So very general. So meaning things like, I mean, look, I'm not you, and I can't picture myself completely in your shoes. But if I do so, it must be awful. Is that correct? So that's limited self. Or I can clearly see that you living on benefits, alone in your flat, not seeing other people all day. That must be quite difficult. Is that correct? That's limited self.
Hello, Patrick. I'm Jack. I'm the clinical director at the Group of Dissociative Studies in London, so working with DID patients.
Yeah.
We generally have a model of treatment lasting over 6 years, so if we're very lucky. And we work mostly in an attachment-based style,
Yeah.
but there can be a lot of patients that get stuck in the stabilisation phase. They can't. I have lots of ideas about why that might be, but I was wondering if you thought that a DIT, because it looks to me more like a stance than a set of prescribed interventions. Would that form an effective and sort of more decisive thing to do in the stabilisation phase of treatment?
I mean, I'm not sure whether I'm going to answer your question, but then you'll correct me, is that I think that what we learn from time-limited treatments is that they do activate a lot. So the arousal increases massively. And so you need to balance this, you need an active stance of the therapist, emphasizing, normalizing, validating intervention on the one hand, but also more challenging interventions on the other hand, because otherwise you kind of stir up the whole thing and don't do anything with it. That's not massively helpful. But my work, I mean, this is the challenge in working with highly dissociative patients. They easily go into this pretend mode as a way to protect themselves from very threatening experiences and feelings and emotions and triggers and so on. But so this is the balancing act. How can we enter kind of that zone of very anxiety-provoking emotions and experiences without the patient retreating completely in a pretend mode? And I think that what we have learned from BIT and from MBT is that you can move into this zone. We have data for this showing that MBT does as well with highly traumatized patients as less traumatized patients. But what we also learned, and this is why we are developing and piloting MBT trauma focus, is that for a number of these patients, we need more. We need a kind of a standalone treatment, module treatment, where there's a lot of psychoeducation involved. On one hand, about their condition, as a kind of balance or attempt to balance what's going to happen when we start to challenge. And I think in literature on personality disorder, the effect size of any treatment increases by 0.2, 0.3 when it includes a psychoeducational component.
Yeah.
So that's massive. And the second thing in MBT trauma focus, what we do is this is group-based intervention. And the group starts with an agreement on the values of the group. And many of the values of the group refer to a kind of safe environment where mentalizing can happen and where the we mode may develop instead of an I or me mode. And we think that that's going to be massively helpful. So these things, psychoeducation, but also group-based intervention, and often as a complement to an individual intervention. We believe less in the notion of individual therapy alone. That's one thing. And the final thing I wanted to say is that this emphasis on epistemic trust and self-genesis to help the patient change in the interpersonal environment. So in MBT, what we now do is we work less, so to speak, with the patient, but more with the system. Because the change doesn't have to happen in the session, in therapeutic sessions. That's fine when that happens, but it should translate to the outside world. And that is where the real change is going to take place. But many of these patients have a very small and often very maladaptive social system, social environment. So we need to help them to change that system as well. And that includes intervention in the real world. So instead, it's like the proverb, it takes a village to raise a child, it takes a village to treat a patient with complex trauma. We just published a book, I should have put it up there, but I'm doing it now, Routledge, where we presented a three-pronged approach to treating children and families with complex trauma. And that is treatment with the child, with the parents, family, and with the system. Equal attention to all three. So again, we are far removed from kind of individual therapy. So we focus on individual, group, and then the whole interpersonal environment.
What's the title of the book?
The title of the book should, if you're complex trauma and mine, this is how narcissistic I am. Complex trauma and other colleagues are the first on, but I think it has to do with complex trauma in time.
Hi, Patrick.
Yeah.
I was hoping we could talk a bit more about epistemic trust.
Yeah.
In particular, how this relates to external factors, psychosocial factors. There was a recent theoretical paper about a lack of epistemic trust serving a defensive function in unsafe environments. For example, if you live on a threatening estate and you have little income, it's probably not helpful to have a lot of epistemic trust. And so I'm interested in these social factors as kind of limiters to developing epistemic trust and how we can promote that in our patients, given their environment outside of therapy.
Yeah, that's a very important. I mean, it's the same in individuals with BPD or antisocial personality disorder, but also in patients with functional somatic disorder. They often have a very, very small social network that is left, which often consists of other people with a similar condition. We know, for instance, membership of advocate groups, for instance, is harmful for many of these people because they tend to only see confirming information that nobody understands them, and it must all be biological, but people refuse to see as biological. That's one thing. And the other members of the social network are often mental health professionals, which is even worse. Real crazy people. So indeed, we need to help them change that network. And what we often see is a change in these patients, of course, partly related to psychotherapy, but happens because of changes in the outside environment, where they meet other people, start picking up a hobby, for instance, or work, and so on. So again, we need to think a bit outside of the box, if you like, and in our treatment programs, not only focus on individual treatment, and particularly not individual treatment in the session, but help patients translate insights and what has been learned to the outside of the therapy session. Like what I think in my treatments from session 3 to 4 onwards, I'm working with the patients to affect changes in the outside world. That doesn't happen only in the ending phase, from the beginning. And that's the advantage of time-limited work as well, because the clock is ticking. So you put a lot of pressure on affecting changes. It's like, have you ever tried to learn a foreign language on your own? So you buy this thing, yeah? It used to be a DVD. My students laugh when I say DVD or a compact disc. Now you buy it online and you start. Una mesa para cuatro personas in Spanish. Very helpful if you go to Spain to a restaurant, because if you enter the restaurant, the waiter has no clue of four guys together are coming to do in the restaurant. So it's completely useless. But you do it one lesson or two lessons, and that's it, and then you give up. But when you are forced to do it for a good reason, and when there's other people also doing it, they upspeed. It's like start to run. If you New Year, they say, I'm going to run on my own every two or three times a week. You do it 2 times. The third day it's raining in London, and it's too cold. The 4th day, and then that's done. But if you have 3 or 4 people wanting to start the run, the other person will say, yeah, but we have to do it. I'll do it. Okay, fine. So this is also the group thing. So we need to help patients to, in terms of salatogenesis, we need to help patients to come in contexts that are much more beneficial, helpful, adaptive than they are now. And that's often a real driver of therapeutic change, extra therapeutic change.
We've got a question from online. Lucy Marks asks, could you say something about working with the system for people with FSDs, particularly with other health professionals seeing the patient?
That's a very good question as well. I think the first thing you would need is to agree as a team on the illness theory. What is often extremely unhelpful is that you are doing marvelous therapeutic work with this patient in your session, and then they go to see a GP, which has a completely different theory than yours. Yeah? It's all stress related. Yeah? My GP told me again it's all stress related. Or I went to see my GP and he has managed to secure me a place in the hospital where I can get a vitamin cure. Yeah? And this helps, I know. Yeah? I did it a few weeks ago and I was better for weeks. So this is helpful, not good by implication. So we need to agree on an illness theory. That's the first thing. And this is where our healthcare system, again, unfortunately often fails. Because we see patients kind of in silo care instead of working as a team to scaffold and to treat and to see and support the patient. And the second thing that is very important is to focus on the social system and to work systematically with the patient to think about other ways of relating to others and becoming involved in more helpful salutogenic contexts. So it's not only about psychological issues in sessions, it's also about, again, translating what has been achieved in therapy to outside of the treatment, which is as essential as what happens inside. Yeah. And this is, again, a change, we believe at least, for how many people are trained. We see that this is the more difficult part of training and supervision in psychotherapists, because they think their task is to focus on psychology. What we are arguing is that that's fine, that's only part of the story. But very difficult.
Final quick question, since we should finish off the wine as well.
Yeah, and the football matches.
So you've mentioned training. How are you envisaging the training? I mean, there was a huge amount in the talk, an incredibly skillful set of different activities and tasks, albeit within a kind of structured model that is reasonably easy to grasp for people. what are you envisaging in terms of then training and what that would look like?
I think we have lots of experience now in training, both from the DIP model, but also from intensive short-term dynamic treatment, the Alan Adams model, which is mostly video-based, and that's something that we learned a lot from. So I think if you're a trained DIP therapist, a one-day training to bring you up to speed with these principles, but real action is in the supervision and the group supervision. So we typically do group supervision, 2 or 3 therapists, bring their cases, and preferably videotape cases. If not possible, there may be reasons for audio tape and so on, but videotape cases are the most helpful, particularly because of the embodied nature of the problem, but also of the treatment itself. So 1 or 2 cases at the very least in group supervision, and then we see that therapists are doing quite well. I mean, that's also been shown in studies where therapists volunteer to do a trial, and if you look at the results, they are very good. They're marvelous, actually.
We have one final question.
Sorry about this. So I'm a GP, I'm not a therapist.
Yeah.
And I've got a background in mental health and somatic symptoms as well. 2 questions, I'm really sorry.
Mm-hmm.
So the first one is, I'm quite familiar with the whole range of presentations, the physical presentations that you've listed, but it's a question as to how you move with the patient to then thinking about things from a more psychological or cognitive perspective. And the other is, we see masses of people, and there isn't much available for them. You know, whether we're well-meaning GPs who might even have some idea of what's going on. What, you know, you're suggesting something, offering something that I didn't know anything about, even though I work in North London. So how do you think this problem should be approached from a, epidemiological, from a community level?
Yeah, I mean, I can't help you with the second question. I have no money whatsoever. You can clearly tell this. So we need to make that a case, because
it means everyone will be seen in the private sector.
Psychotherapy is hugely not only effective but cost effective for these people. Hugely cost effective. It doesn't cost almost anything in psychotherapy compared to all the kind of medical treatments and examinations and medication and GP consultations. I'm sorry for this, and so on. So it's usually cost effective. So it's our job to make a better case for the cost effectiveness of psychotherapy and for the idea of a network of professionals treating, seeing and treating and managing these patients. So we should move away from the siloed care to networks, treatment networks. And regarding to your first question, indeed, what typically happens in my consultation is something of the following. The patient says, I'm referred to you, but I'm not sure why. My GP told me to see you because she thought that perhaps stress could have something to do with it, or it could be all in my mind, or she said it politely, but perhaps that the psychologist could help me, but I don't believe a thing about what psychologists do. And instead of responding to that, like I used to do in the past, but we know it's stress, and we know that emotional factors, and sometimes, I say, oh dear, that must be awful. So you have this awful condition. I can clearly see how you suffer. You barely managed to get up the stairs to my office. And there was some GP or medical doctor telling you that could be all in your mind. Gee, how does that make you feel? But typically that happens when the patient starts to cry. This is the effect I have on many people, I know, but jokes aside, this is actually what happens. And then they say, look, so that's unconscious alliance. That's what we call unconscious alliance. Something different might happen here. There's still a lot of epistemic mistrust and even hypervigilance. But there's also the feeling that this relationship might be different. So that's typically the starting point. So refrain from any discussion about illness theories. Yeah? Acknowledge, validate, normalize the experience, subjective experience of the patient, and focus on the suffering first. Yeah? I often have found myself saying things to people like, if you have diabetes, this has an enormous or cancer has an enormous impact on your life. I can't help you with the cancer or the diabetes. Doctors maybe, I can't help you with that. But I can perhaps help you with the impact that the diabetes or the cancer has on the individual. And similarly for you, I can clearly see that you're in pain. I'm not sure that I can do anything about the pain, but I can help you, I think, with the impact the pain has on you, because you can clearly see its impact. You're trying now, you're suffering. This is my area. You know? I know something about this. So I even presented myself as a coach of pain, a pain coach. I can help you perhaps to deal with coach you perhaps with the impact this awful pain has on your life. And using the term awful pain, I'm already emotionalizing. Is that an English word? I'm already bringing the emotions in it and relationships in it. So you gently kind of move that, but never argue. I think there's a British Peter Hobson, I forgot his name, who said, arrive at an illness theory by consensus, not conflict.
Thanks very much. The NHS workforce plan includes another 3,000 therapists being trained in 2023-24, and we need GPs like yourself to be insisting that some of those therapists are trained in the things that Patrick has been talking about, because there is a training commission already for dynamic interpersonal therapy. Those therapists should be within the NHS talking therapy services. But the GPs need to be insisting that the patients can get access to them, so that the training ramps up a bit more over the next year. Thank you. So thank you very much, Patrick, for a very rich talk this evening. And as I say, we will make it available so you can watch it all over again at your leisure. There was a huge amount there, so I think people will need to revisit it. Welcome then to more drinks for the rest of the evening. We need to leave at 9, and those people who want to catch the tube will need to get to the tube before 9, because apparently it closes then. Thank you.